I'm Dr. George Delgado, the president of Steno Institute, increasing research, education, and awareness around abortion pill reversal. We're giving women a second chance at choice. I'm also the president of Delgado Medical Consulting, helping small and medium-sized businesses stay open during the COVID-19 pandemic. And I'm the medical director of Culture of Life Family Services. In today's talk, we want to know what are the important considerations around artificial hydration and nutrition. So this is a very big topic. We're going to try to hit the highlights here in this short talk. Well, first of all, it's important to know first what is artificial hydration and nutrition. So essentially what we mean by this is intravenous fluids, feeding tubes, total parenteral nutrition, which is high-level complex nutrition, including amino acids, electrolytes, glucose, and sometimes lipids through a central vein or through a peripherally placed intravenous catheter that goes into a central vein, as well as sometimes what we do in hospice is hypodermal clysis, which is subcutaneous hydration. And this is simply like an IV, but the catheter is placed under the skin into the subcutaneous space. It has the advantage of allowing continuous provision of fluids without the danger of a vein blowing out and losing the IV site. The disadvantage is that it cannot be given at the high volumes that an intravenous line can. Many medications can also be given to the subcutaneous route. Now, the Catholic Church considers access to food and water to be basic rights, and I think most people would agree with that. The Church also feels that no matter how that fluid or nutrition is given, whether it's the normal way by mouth or whether it's by a tube, that it should be considered part of ordinary care. That's a very important point to keep in mind that I think makes very good sense. However, these days in hospitals and in Western medicine, it's really considered life-prolonging medical care. And sometimes it's even seen or described as curative care. But we really should point out is that it's only life prolonging in that it prevents dehydration and starvation. It's only really maintenance. And sometimes the argument is made, well, we have a demented patient and is getting intravenous fluids, but the dementia is not going to improve from intravenous fluids. Well, it's asking the wrong question, because you shouldn't really expect intravenous fluids or artificial nutrition to improve dementia or to improve Parkinson's disease. Rather, you should look at it, is it going to prevent the early death from dehydration or starvation? Because the goal really should be not for the patient to die from dehydration or starvation, but from the patient to die from the disease itself if disease-modifying measures are burdensome. So I think it's better to frame it that way in order to better answer the ethical questions. Because unfortunately, often as part of so-called comfort care, near the end of life, artificial fluids and nutrition are stopped. Going back to the Catholic teaching, what the Church has taught in the last several years is that fluid and nutrition, no matter what the means of provision, whether it's given naturally or artificially, should be given by default. In other words, the presumption should be that we will feed and hydrate our patients. There are some exceptions, however, and we're going to go over those and give a few examples. The first is if the artificial nutrition or hydration or even mouth feeding is burdensome, then it should not be expected to be given. When might it be burdensome? Well, for example, if you're feeding a patient and with every single bite, the patient aspirates and coughs violently, well, then if you can't find a way to feed that patient orally without causing such discomfort and risk of aspiration pneumonia, then you probably shouldn't be doing it. You should look for another way to give that nutrition. Secondly, it's something that doesn't often come up, but cost can be an issue. So this usually doesn't happen in our country, but there might be instances where a patient doesn't have any access to health insurance and has no coverage whatsoever, and the cost of providing IVs or of providing feedings through a tube might be excessive. This would be more commonly seen in third world countries. And in fact, after the church came out with some of its documents about artificial nutrition hydration, some bishops from the Philippines gave a mild clarification or even an objection, stating that in their country, that artificial fluids and nutrition are not readily available as they are here in the United States. So cost and availability actually could be an issue because it might be a burden on the family or the patient to actually obtain intravenous fluids or tube feedings. Next would be with tube feedings, and these tubes are either given nasogastrically, oral gastrically, or sometimes percutaneously, where a tube is inserted through the abdominal wall into the stomach. Well, sometimes the provision of these formulas through these tubes can cause excessive diarrhea. And excessive diarrhea then could lead to skin breakdown and to a lot of problems for the patient. We see this particularly in demented patients, and this is one of sometimes the reasons where these feedings have to be adjusted or even stopped with dementia patients. Sometimes the fluids that are given through the tubes into the stomach don't go down into the intestines fast enough, and they actually can be aspirated into the lungs, causing aspiration pneumonia. So sometimes we can deal with this by putting in a longer tube that goes into the jejunum, into the small intestine. However, sometimes even that's not enough and they still aspirate. So the burden of aspiration sometimes can be such that the patient should not even be given feedings that way. Sometimes with tube feedings or with intravenous feedings, we can cause fluid overload. If the patient has very tenuous congestive heart failure, the fluids given can cause overload and cause worsening of the congestive heart failure and trouble with breathing. In those cases, they should perhaps be turned down, but sometimes some patients can't even tolerate them that way. Sometimes patients, especially those who are demented or those who or for one reason or another are combative, will be pulling tubes out. And the patient is pulling the tubes out several times. You may have to decide, should we restrain the patient, or would the restraint cause more burden and perhaps we should not be feeding the patient that way? Other times, the patients might be so frail that they may not tolerate the relatively minor procedure of inserting the tube if it's a percutaneous gastrostomy tube, often called a PEG. Some patients are so frail they will not tolerate the mild anesthesia needed for that, or will not tolerate the procedure itself. So in those cases, those procedures should not be done. The next category where the church says that artificial hydration and nutrition are not mandatory is when the fluids or the nutrition are not being assimilated. If, for example, the patient's veins are not working, or the patient's intestines are not working, the patient has such bad congestive heart failure that nothing's being absorbed from the intestines, or if the patient is not moving the bowels at all, has an ileus, then at that time, tube feeding would not be assimilated and would not be useful, and actually would cause more burden than benefit. And lastly, if the hydration or the feeding is not attaining its finality, in other words, it's not helping the patient to remain hydrated or to remain fed, or if the patient is close to death and whether or not the patient gets fluids or nutrition would not matter. In that case, then it would not be mandatory to give it. So it's important in all of these cases to conduct the ethical analysis, even if it's very brief, to determine if artificial hydration and nutrition is indicated. So you want to look at the patient, see, first of all, is it at all possible to continue with oral feedings, even if it's just spoon feeding? Because that spoon feeding is always safer than any kind of tube feeding or any kind of intravenous fluids. Perhaps repositioning the patient so the patient does not choke or aspirate would be beneficial. And we feel that the human-to-human contact of a person spoon feeding a patient actually has a very salutary effect, has a very beneficial effect on the health for that patient. Because we have to remember that as medical professionals, probably the best treatment we can bring a patient is ourselves, just that person-to-person contact, touching that person, loving that person knows that he or she is being cared for. So we conduct that ethical analysis, and it's always important to remember that we only withhold the fluids and nutrition, essentially, if they're not attaining their finality, if they're not being assimilated, or if they're burdensome in some way, because we want to do our best to make sure that patients do not die of hydration or from starvation. We want them to die of their diseases, of their natural causes. So keep all these points in mind. Thank you very much for listening. I'm Dr. George Delgado, the president of Steno Institute. Have a great rest of your conference.